first start. Now we would like to invite our next four panelists, Dr. Tien Lee, Dr. Zafar Usmani, Dr. Adam Nelson, and Dr. Kashif Koka to come and take a seat up at the stage. I think we're missing one of our panelists. Oh, he's not here? All right, that's all good. We would like to again welcome endocrinologist Dr. Tien Lee to speak to us about metabolic syndrome and diabetes.
All right, just a quick thing. I just check again. Okay, it's good. All right, so I'm Dr. Tien Lee. For those who are new here, I'm an endocrinologist, and I spoke about metabolic syndrome earlier today, and I'm just going to move on and talk about metabolic syndrome and diabetes. So this second session, in my view of it, looking at the program, is actually already after the metabolic syndrome has now an organ problem, so to speak. Okay, it's not just a syndrome now. And as I said, that the prevalent treatment for metabolic syndrome is to treat the individual components. But I'm going to challenge that a bit with my talk today and say that we should be treating the metabolic syndrome as an entity of its own. So there is this debate that is ongoing in the research world as well, whether we should treat metabolic syndrome as an entity of its own or we just treat the individual components, whether there's any benefit. So anyway, this session is actually a bit late. Patients with metabolic syndrome, nothing done, now continues to have problems. First problem, of course, diabetes, which I'm going to talk about, and later on other speakers are talking about other things related. Now in the third session, of course, we are actually talking about those people with metabolic syndrome and potentially without any problems yet, and we can potentially reverse that. So the first thing is a reminder. My view is that it is metabolic syndrome in the history that I went through earlier. You notice that it is, as Dr. Prashant, the psychiatrist, was saying, it was for looking at this cluster of risk factors, so to speak, that may predispose to cardiovascular outcomes that is not good. So it doesn't actually tell us about the underlying mechanism, doesn't actually give us a target to actually treat. Yeah? So I like the fact that some of the studies and some of the thoughts right now about metabolic syndrome is that it centers around something called visceral adiposity. And that's actually the way that I would look at diabetes nowadays as well. Okay, so that is that. And from visceral adiposity, you get everything else, including the insulin resistance. Actually, diabetes itself is a pro-inflammatory condition as well. So all of these actually can work together, and then you end up with diabetes. Okay, so disclosure, I get nothing for today, but I get bribed by everybody else. So I'm not going to be, actually one of the slides actually came from one of the drug companies, but just remember nothing about it. It's just because that slide was easily available from their website. So I chose that to demonstrate what people are talking about nowadays. Okay, so I would start off with a case this time, slightly different in my presentation. And those who have actually attended one of my talks some years back, it's a nationwide talk, I think by Think GP, on GLP-1. This is actually modified from that talk, okay? So, but hopefully it's still useful. So I will start off with a first case. It's about a patient with diabetes and complete remission. Now, I'm going to say that remission in diabetes is a very confusing word, so I just need to clarify that. In the Australian ADS guidelines, it's 3 months off medication, HbA1c under 6.5%. In the American Diabetes Association, it is 6.5% as well, HbA1c, 12 months off medication. To me, none of these are actually remission. You know why? In the past, we used to call it lifestyle controlled diabetes. What is the remission here? How do we just relabel that whole class of patients and say, oh, it's in remission? They still have diabetes. So I actually use a slightly different term. So I call it complete remission, but actually now I have a different word that I use sometimes. I say no detectable diabetes. In other words, if these patients come to you and they say, I don't have diabetes, you do whatever test you want, they will still not be able to, you will still not be able to show that they have diabetes. That's what I mean. Okay, so 28-year-old male, okay? Past history has hemophilia A, sleep apnea, and type 2 diabetes. So, of importance, of course, hemophilia A, every time I check the HbA1c, I will make sure that he's not anemic. If he's anemic, HbA1c is going to be artificially low. Yeah. So, but if there is no anemia, hemophilia A, HbA1c is still reliable. With type 2 diabetes was diagnosed. Now, this is a patient who is a physiotherapist, so one of the healthcare providers. The parents are both GPs. He's very upset that he got diabetes. So he came to me. Original weight was 78 when I first saw, but by the time I spoke to him about, somebody brought up about bringing it up. So I brought it up not on the first consult, but I brought up that there is a different way potentially to treat diabetes. Okay, and by the time he has already lost some weight on his own. Okay, so 75.6 when he went into what I call the lifestyle management pathway for people with diabetes, for myself. And BMI is not that bad, it's 26. Okay, now, the target that he wanted was 70, and he did achieve it at some stage, but I actually stopped all medications in June, so he actually eventually had a slight increase in weight. Now look at the amount of weight loss, very modest. And I purposely put this case at the front because much of research that we have on metabolic syndrome, on reversal of diabetes, remission of diabetes, is based on weight. And I'm going to tell you that I personally think that that is because weight is an easy measure. It's much harder to check visceral fat, isn't it? Right? So because it's that easy measure, all our research is from that, but it is a confounder. It's almost like saying it's easier for me to check whether a person has a cigarette lighter in the pocket and lung cancer versus actually checking that they are smoking or not. But it's a confounder. The cigarette lighter, you take it away, hey, look, less lung cancer too, but actually it's because they smoke less. Okay, so that's why I think it's still a confounder. Now, medication that I put him on was metformin. I won't go too much into the choice of dulaglutide and semaglutide later on. This is not a GLP-1 talk, but certainly it helps with weight management as well. And then in the end, I stopped everything anyway. Look at what happened. When he first came to me, he was on 1 or 2 drugs. I can't quite remember. I think it was 2 drugs. I think it was actually a SGLT2, which I stopped eventually. And it was HbA1c was 9.8% at that time. So he actually had very bad sugar despite being newly diagnosed and putting onto 2 medications because he didn't change any lifestyle. He's still eating that quarter chocolate cake after every meal or something like that. Okay, so that was still 9.8%. But look at that. By February of 21, so this is several years ago, HbA1c is already 5.3%. Now, I use 5.7% as my cutoff for remission because 5.7 to 6.5% is actually the pre-diabetes range. 6.5 and above is the diabetes range. So if you still have pre-diabetes range, it means that somehow, somewhere, you still have signs that you have diabetes. So I don't consider proper remission. So, and in fact, it reached to 5%, not data are not shown, okay, where I got him to do a glucose tolerance test. Remember, he stopped in June, so this is 4+ months post stopping everything. And look at that, OGTT is 5.2. Now, before Shalim thinks that we should send everybody for this OGTT post-bariatric surgery and show that they have no detectable diabetes, unfortunately, this criteria cannot be used post-bariatric surgery because the gut transit time changes. The OGTT is not reliable post-bariatric surgery. Okay, so just remember that. Having said that though, there is still no published case that I'm aware of that has this form of diabetes remission. I only know of maybe one more. the 5 patients that I have up to today, and one of the doctors at Kangaroo Island recently said that he had a patient who lost lots of weight and also managed to achieve something like this. So I don't know, that one is not confirmed. Nothing published as far as I know. None of my colleagues have mentioned similar results. So, so that is that. More excitingly to me is I spoke to his parents who are GPs, as I said, and I said, oh, how's your child coming along? And son, okay. And he said, oh, maybe send you back. And I saw him this January. The sad thing is, his weight came back to baseline. Baseline is 76, okay, not the 78, okay. But the good news was, HbA1c was still 5.4, off medication for 3 years now. Remember, the data was 2021 when it first started. So that to me shows that there is a more lasting effects. And I'm sharing this, and I'll share another case at the end, mainly not to tell you all to promise anything. I don't promise anything to my patients, despite having these results, but to give hope. We always think of diabetes as a chronic progressive disease, but because if we look at it as a metabolic syndrome and we treat it that way, we might have a different outcome. So I'm going to continue. Yeah.
So on this case, did you check their insulin levels at that level? Maybe in the OGTT, did you check insulin as well?
I did not check the insulin levels. Part of it is I do know that insulin level. The question is, did I actually check the insulin level with OGTT, etc.? And the reason for people trying to do that is to look for insulin resistance. So you can estimate something called HOMA-IR with fasting insulin and fasting sugar. You can calculate a Matsuda index if you are using OGTT with that. But those are actually research tools. So at this moment, I don't, okay? And there is different opinions on that. If you ask older gray hair endocrinologists, they will say, nonsense, how can you be doing this? It's not validated for that use. You understand what I'm saying? So I'm not going to, so I've not done it in my normal practice. And really, is there a reason to? Because it doesn't give us anything to change management. Okay. I don't have the answer because I didn't do it. I don't generally do it, but I have started doing some fasting for HOMA-IR. But look through the rest of the talk and you realize that it would probably come back normal. Okay, so I'm going to talk about the way that I look at diabetes and the way that the world is looking at diabetes now, the paradigm shift in the way that we think of diabetes, okay? In the past, we think of it as a single metabolic condition. It's all about the sugar. And then whether it's the GP or the endocrinologist, we look at whether there's complication, we do screening. In the past, we didn't even do screening. We wait until complication happened and then we send it on. In some sense, that might be what we're doing with metabolic syndrome right now, isn't it? And we continue, and then if they have macrovascular complications, then we send it off to the cardiologist, etc. And then if they have problems with the eyes or the kidneys or whatever microvascular complication, we send it off to the other specialties. Now, this is a very reactive model, and that is the problem. And guess what? It's not that long ago. Look at the American Diabetes Association, this is American, 2017. If you look at the ADS guidelines and RACGP guidelines, they still use the ADS guidelines, the old one, not the living guidelines. It's still very similar. Pretty much the first thing is, what's the sugar? Lifestyle. What's the sugar? Metformin. What's the sugar? Oh, yo, let's go second line. Those are the choices. What's the sugar? Oh, still bad. Let's go third line. So it is all very glucocentric. That is the way that we have been doing it. And I think it's time for us to change. And luckily, in some sense, things have changed. If you have talks from Boehringer or Eli Lilly for Jardiance or Jardiamet, or you have talks from AstraZeneca for Forxiga or Zigdo, you are probably going to hear this word, cardiometabolic renal syndrome, okay, or condition, multi-system disorder. So this is actually an improvement. So instead of looking at diabetes as a single metabolic condition, this one is ripped off Boehringer's website, okay? So that's one. But it's the same thing if you have AstraZeneca's slides, you have similar slide deck. So what is actually happening here is they think that, look, they are all intertwined. Think about kidneys, they are nephrons, isn't it? What are nephrons? They are blood vessels, isn't it? When blood vessels are there and they are impaired, guess what? The coronary artery is also blood vessels. So not surprisingly, we have all the data to show that if you have diabetes, which is the underlying thing, and then you have renal impairment, your risk of having a cardiac event is much higher. Not surprising. So that's why they say it's intertwined. And let's just address all of them at the same time. Of course, it benefits them because SGLT2 is renal protective, is cardiac protective. I think we heard from AstraZeneca just now as well with their Forxiga. And it addresses all those other comorbids. Now, I think, and certainly the guidelines have changed as well. This is from 2022. I didn't update the slide, partly because it was it's part of the history that I'm going through about how we are looking at it. So in 2022, for the first time, we had the statement from ADA, American, that instead of always including metformin as first line, remember the 2017 is metformin, they actually now changed to generally includes. Those small little words in all these guidelines are very sneaky, isn't it? Means that you can have no metformin, isn't it? So, in fact, the very latest one, they no longer even have that statement anymore. The first thing is to look at whether there is any cardiac or kidney disease risk. Okay? And then you put all the other medications to help with the other comorbid problems. All right? And then, guess where, if we look at it as a metabolic syndrome, where does it lie in this model? Weight. It's only an afterthought after we have addressed those cardiovascular renal problems. Then as an afterthought, we think about treatment inertia, choose something strong, and we think about weight as a bonus. Now, if we actually look at it from a different point of view and from a more metabolic syndrome point of view, perhaps that should have a bigger impact. So, I'm going to move on to say something that I'm going to present about in terms of diabetes is that it might probably be better to think of it, or maybe it's the next paradigm shift that we need, to think of it as part of a metabolic syndrome or perhaps a multi-morbidity of obesity. Now, what is the difference between multi-morbidity and this CVRM? Now, CVRM model is a comorbid mentality. That's the way I look at it. In other words, you have diabetes and you have all those different complications, comorbidities. And then when we treat it, we are going to treat each of them individually. Yes? The multi-morbid, and I know that word is also misused now, but I believe it was first coined in the Lancet back in 2014, where they introduced this idea that if we have something, let's say obesity, that underlies a lot of these comorbid conditions, we call it a multi-morbidity of obesity. Okay? And the idea behind it is that we have a treatment target as well. If we actually address, if it is obesity, we address obesity, we will lighten the load of all the other diseases above it. So it's a very different mentality. The comorbid is top-down. We are actually addressing all the individual problems, while the multi-morbid mentality, or we can say metabolic syndrome mentality, would be actually to address the thing potentially underlying. Okay? So, so that's there. And if you look at obesity as the model, as I said, most research are based on obesity, you're going to see that we have all those things that we worry about in diabetes anyway, as part of the obesity circle or whatever. Okay? And Lancet had a follow-up publication in 2022, which talked about complex, that means 4 or more, multimorbidities. And why I'm presenting it here is just to show that all the things associated with multimorbidity of obesity includes all the things that we talk about with diabetes care anyway. Look at that, endocrine diseases, of course, but diabetes, of course, but sleeping disorder, sleep apnea, for example. We have, I think somebody is talking about that as well. There you go, next. And then sleep disorder is not just sleep apnea, okay? Then there is hypertension. We have also heart failure. In fact, heart failure's link to obesity is stronger than that of the ischemic ones. Of course, ischemic, they have differentiated them out Okay? And then if you look at kidney, renal failure is in there as well. And so is gout. And so all of those things that we normally think about in either metabolic syndrome or as complications of diabetes or obesity is all actually encompassed in this model. Okay? And so that is a potential. And why is this actually more and more relevant? Because we actually have new interventional studies that are actually suggestive that potentially treating the underlying problem can help with diabetes. This is direct trial. This is the original. They actually published one more last year as a 5-year follow-up. So this is the original one. So they have multiple publications, very smart. Just one study, multiple publication. This particular publication was actually looking at the endocrine function of the pancreas and the imaging. So this is the MRI. This MRI is, they blacked out all the part that is not the pancreas. On the left side, the baseline, that is a picture of somebody's pancreas after about, say, 10, 15 years of diabetes. The one on the right side is somebody with no diabetes. Can you all see the difference? Huge difference, yeah? And you know what? In this particular study, by the way, it's a GP-led trial, not endocrine, huh? Not us. It was the GP in UK. They actually did weight loss. 5 months. Look at that pancreas. And then if they continue not losing more weight, but maintaining that weight loss, 12 months, 24 months. 2 things to notice. 1, it's not a cure. That pancreas is still different. So there is no cure for diabetes. I think I mentioned it slightly just now. I just need to double confirm that there is no cure for diabetes. It was only in a lot of talks they said that is bariatric surgery a cure for diabetes. We don't believe it's a cure, but remission and long-term remission, potentially. But look at that pancreas, much better, isn't it? Okay? More important than that and more spectacular than that. Well, this is spectacular because we never had those imaging to show us what happens with type 2 diabetes. This is not type 1. Okay? Is the endocrine function of the pancreas to us, endocrinologists, simple people, is insulin production. Okay? So what is the maximum insulin production? No diabetes, diabetes. Half the amount of that insulin. Okay? And guess what? After the weight loss, 5 months, 12 months, 24 months, after 24 months, even though it looks different, there's no statistical difference between the amount of insulin it can produce now. Now, I'm glad for this, okay? The way that they did it though, unfortunately, for the weight loss is not very effective and not very good, okay? Only about slightly over 10% managed to do the weight loss that they wanted. But it's good to have this result because it teaches us about what weight loss or addressing something underlying can do to the patients. There's a lot of people who then ended up with under 6.5% off medication on this as well. However, in the follow-up, there's only about 5 people who managed to continue keeping their weight down. So I hope that in the 3rd session, I'm sorry I can't be here, we will have some means. Of course, bariatric surgery is one of them, but even potentially with medical means that we can keep the weight off longer than what we have in this direct trial. So the way to do it is not quite right, but if you can do it, that's the results. This one? Yeah.
Yeah, just on this slide, just have a question for this slide. So I was wondering that with the type 2 diabetes or the metabolic syndrome is the problem with the insulin resistance. So I thought the insulin level at the time of the diagnosis would be higher.
At time of diagnosis, correct.
Non-diabetic patients. So.
Okay, so the beta cell function loss actually happens even in the pre-diabetes range. But despite the fact that the maximum insulin is reduced, the measured insulin, when you measure it, will be higher in those patients at the early parts of diagnosis. So this is maximum insulin production from the pancreas. Okay, so the question was yeah. So really it is higher when you first find the patients with type 2 diabetes, not because their maximum insulin is increased, it's actually decreased, and it decreases even from the pre-diabetes time. Very well documented. I can show you other graphs if I have in the future, or come to me. I have it in my computer. Okay, so let's go on from there. Okay, so more interestingly, I don't think it is weight. Remember my first case? I think it's actually visceral fat, and very, very few research out there. This is from 2018. I believe it was a Chinese group. Okay, and what they did was actually they looked at people with the visceral fat done by CT scan, not even DEXA. Very good. So very accurate. Okay. So you have the baseline, and they did something. 6 months later, they decreased the visceral fat. And then after that, they changed the management, and then the visceral fat starts to come back. What was it? It was exenatide, and this is Byetta. Twice a day. You know, we never think of Byetta as a weight loss agent because it doesn't lose much weight. In fact, we were very happy that it was even weight neutral at that time. So you lose about 1-2 kilos maybe in this research. 1-2 kilos is not a lot of weight loss. But you know what? It seems that they managed to lose a lot of visceral adipose tissue. And with that loss of visceral adipose tissue, and then when you switch to insulin, it starts to rise. But there is a delay, a time delay. And in fact, I shared this with the patient I talked about in case 1. I said that this might be because there's a delay. If you're not doing the right things, you're going to start accumulating your visceral fat again. Okay? More than that, that is HOMA-IR. Remember, we talked about looking at insulin level? Insulin level and fasting insulin and fasting sugar is all you need to calculate HOMA-IR, which is a way to estimate the insulin resistance. Look at that drop.
1 hour and 2 hours post.
Sorry, there's a question about looking at insulin resistance with the 1 hour and 2 hours post in OGTT.
1 hour and 2 hours, you don't count that?
I generally don't use that because HOMA-IR is by far the most common measure for the insulin resistance in literature. But there is a Matsuda index that you can use to calculate. There's calculators online. So you can use that if you want. But again, all of this is research basis. Clinical relevance, don't know. That's why I said if I have more white hair than I do and some beard, I might be telling you, please don't worry about these measures, okay? But I'm a bit younger, so I realize a lot of people are interested in it. So anyway, so HOMA-IR is an estimate, okay? And you can see the big drop in the insulin resistance, okay? And despite this going up, it's still statistically lower. The insulin resistance doesn't immediately rise. Now, we don't have enough of papers to give me and for me to tell you that this is always going to be the case. But it seems to me that there's a lag time, and it does make sense because naive adipocyte, like any naive cells, they don't suddenly produce everything. They mature, they produce more hormones, they cause more problems, they have more stress, and then you have more insulin resistance. So it has a lag after you have the visceral fat and then coming back up with more insulin resistance. So I will share one more quick case. This one actually had very significant weight loss. Maybe, I don't know why, I guess my original presentation had it, but I guess this is just to redeem myself that I'm not terrible for weight management. The other one actually regained all the weight. So this is a 22-year-old female actually seeing me for thyroid. Remember I mentioned about the fact you don't have to bring up obesity necessarily, but when you treat them. So I just noticed, hey, hang on, your diabetes is not very well controlled, 7.6%, would you like me to help you? And maybe I can help you in a different way that other people have not been doing. I'm going to talk about lifestyle and stuff. And so guess what? She said yes. And so she was only on metformin, and then I started on, this is Ozempic, and titrated up to 1 milligram. And look at that. I stopped all medication by August 2021, not done at that lab, so that's why I don't have that result. So look at that, 4 months after, HbA1c is 5%. Weight loss, was 71 down to 58. So that's quite significant percentage total body weight loss. 71. Yeah, Asian, so a bit short. Okay. Okay. So look at that, 5%. But of course, that was August, right? This is August 21. This is April 22. So April 22, guess what? 8 months later, OGTT has still normalized. Now, none of the 5 patients that I had that have this kind of results have ever come back with diabetes again. I'm not going to tell you it's a cure. It's definitely not a cure. Okay, they do the wrong things. Like the first patient, I said to him already, I said 3 years now, still very good. But if you do the wrong things, there is a time lag from what I'm seeing in the data. You will probably start accumulating and get it back again. Now, that's that one. Okay, so really, I think maybe there will be a paradigm shift in the next 10 years, my opinion. Okay, that type 2 is still going to be a chronic progressive disease, but there is hope. And I think I share these cases in the past and now also to say that there is a hope. And we tell people that you are on a journey, the diabetes journey. And the only thing at the end of that journey is that tombstone. And in between, you lose your limbs. What kind of things are we telling them? But if we tell them that, look, there is something you can do about it, and you can actually change potentially the food that you choose, the things that you do, address the metabolic syndrome underlying. And I actually can tell them, I have patients who have done it, and this is the result. Would you like to do that? About 80% of my patients would choose to do it. Okay? So, but even complete remission, as I said, is possible, and that's why I say it's a chance for hope. Okay? And it's a possibly better way to treat type 2 diabetes. I say maybe a paradigm shift someday, because as I said, the current guidelines, doing these kind of things and addressing metabolic syndrome is an afterthought. We look at CVRM first. And I still do look at CVRM anyway. But then I also think that it's important for us to think about what's underlying and treating that as well. So it is not a cure. So I think best thought as part of the multimorbid or metabolic syndrome rather than an entity or glucocentric entity metabolic-wise. And treating the underlying problem may actually turn out to have a better outcome. Okay.
Thank you so much, Dr. Lee. I would now like to invite up Dr. Zafar Usmani, who will be speaking today on obesity and sleep apnea. Dr. Zafar Usmani is a senior respiratory and sleep medicine consultant at the Queen Elizabeth Hospital and Northern Specialist Suites. He also serves as a clinical senior lecturer at the University of Adelaide and examines for the Australian Medical Council and Fellow of the Royal Australian College of Physicians. As the past president of the Pakistani Medical Association of South Australia and former committee member for RACP State Committee, he holds significant leadership roles. Dr. Usmani's main research interests are management of anxiety and COPD and new modalities for treatment of sleep apnea. Please invite up Dr. Usmani.
Thanks, Mael, and I'm a committee for organizing this amazing seminar and inviting me to it. I wish Tien would have asked for something else. Here is a man with no hair or gray hair and a beard. So he mentioned about it twice, so I was looking at myself not long. No, I'm not an endocrinologist, so anyway, we'll talk about sleep apnea. I feel like try my best to engage the crowd on the right as well, because this dust is slightly settled there. So, but if you guys have any questions, please feel free to intervene. We have Dr. Suleiman, another respiratory and sleep physician there, so she can probably add on if I won't be able to answer your questions. Anyway, so we'll be talking about sleep apnea generally, about the diagnosis and treatment, but also in the second half of the talk, I will talk about the cardiovascular and metabolic consequences of untreated sleep apnea. I usually tend to speak fast, so please feel free to interrupt and ask me to repeat things if I'm going too fast. There's not much point in me going through and if it's not getting conveyed. So basically, sleep apnea and obesity are two of the common conditions which are seen in general practice in Australia. And obesity is the major risk factor for sleep apnea. And nowadays, we have quite significant evidence that there are a lot of cardiovascular and metabolic consequences of untreated sleep apnea, so we'll talk about that as well. Before we go there, this one? Okay, so sleep generally is ignored in not just medical community, but also in common community. However, we spend about 1/3 of our body time or the lifetime in sleep, until unless you are leader of one of those 57 countries who are in deep sleep since last 7 months. But anyway, so though we are sleeping, still there's significant physiological changes happening in our body, which include endocrine, cardiovascular, and respiratory systems, and it does have an impact. If your physiology is not functioning, if you're not having a good sleep, then it leads to significant consequences. Caleb, can you show us what can happen? There's plenty more, but I'll probably stop here for the interest of time. But what it shows that how sleep medicine initially started, basically we're concerned about sleep apnea and the tiredness and sleepiness and drowsy drivers and everything else. But moving on, we'll learn more about what else could happen. Generally speaking, sleep is basically divided physiologically into REM and non-REM, and both of them have their independent and separate functions that they perform during the sleep. So basically, this division is mainly based on the EEG and the muscle tone, everything else, but the cardiovascular system, sympathetic system, parasympathetic system, and respiratory and endocrine system perform different tasks during those phases. So if any of the phase, for example, REM is suppressed, then it can precipitate sympathetic drive and everything else, so which could lead to significant problems. So where's the pointer? So this is the pointer. So as we can see here, basically cerebral blood flow goes up in the REM sleep, particularly in the phasic phase, and then significant other changes in airway resistance involves all of the system. So any sort of change or disproportion in the system will lead to significant issues. In addition to the physiology, which we'll discuss more later on, anatomy also plays a role. So this on the left is the upper airway section of a patient with sleep with normal and healthy men. You can see there's enough space in the upper airways, whereas here is the patient with sleep apnea with big tongue and increased genoglossus muscle leading to narrow airways. So sleep apnea is basically characterized or defined as a partial or complete collapse of upper airways, which leads to oxygen desaturation, intermittently reversible, and which then leads to sleep fragmentation and hence sleepiness or what other causes. Sleep apnea syndrome is when you have elevated AHI along with the daytime sleepiness. OSA is quite prevalent. Most of the studies about the prevalence is from North America, and it shows that generally speaking, the prevalence is about 20% for moderate sleep apnea, and is basically more common in males. In Australian studies, the data is quite variable, but again shows very similar results. If you talk about moderate sleep apnea, about 20% of Australian population has moderate to severe sleep apnea. And if you talk about any degree of sleep apnea, this was an Adelaide-based study at the bottom with home-based polysomnography and Berlin questionnaire, and that showed prevalence as high as 49% for any type of sleep apnea, including mild sleep apnea. So it is pretty common in our population as well. Obesity is the most important risk factor for sleep apnea. And as Tien has mentioned, and I'm pretty sure Shalim will talk more about it, basically up to 60% of sleep apnea is contributed because of obesity as a single risk factor. And here, this study actually showed that the prevalence or percentage or risk of sleep apnea, if you are a normal BMI patient, is about 11%, which goes up to 21% in patients who are overweight, and up to 63% in obese patients. So basically, the risk approximately increases by 6 times if you are a healthy, normal weight person to an obese person, by 6 times to having sleep apnea. There are some other factors as well, anatomical factors, for example, craniofacial anatomy. So amongst Asian population, it has been shown that they got same sleep apnea severity at a BMI of less than 2 kilograms per square meter. So obesity, as I said, is the major risk factor, but it's not the only risk factor. So if you're seeing a patient who is basically has symptoms of sleep apnea, tired, and you can't find any other cause, but they're not big, don't think they cannot have sleep apnea. There are other physiological factors here. Very briefly, this is one of the common physiological factors, which is loop gain. Basically, just corrected, is basically the respiratory center overreacts to the degree of hypoxia, and just a cycle goes on overcorrection, which leads to loop gain. In Sjogren's syndrome patients, they have a lack of surfactant, which leads to high surface tension and then collapsibility. So there are other risk factors for sleep apnea as well, not just the obesity. So if you see a patient who has symptoms, but they are normal BMI, they have normal BMI, don't ignore sleep apnea, please. Diagnosis is not much different than any other disease. Obviously, you would go through the history, examination, and then diagnostic tests. The most common presentation of sleep apnea is usually the partner's reported snoring. I'm glad Medicare hasn't got hold of this treatment option yet, otherwise this would be in the guidelines. But anyway, most of our patients don't have a patient partner, so obviously the most common presentation is snoring. Obviously witnessed apneas, morning headaches, tiredness, and daytime sleepiness. Examination-wise, there's nothing much to find or specific for diagnosis of sleep apnea, except for what you would expect from obesity. Again, increased neck circumference and waist circumference. Then you will obviously anatomically you would check the Mallampati score, and then they have retrognathia or a big tongue. In terms of cardiovascular, you will see loud P2 or pulmonary hypertension signs. But it's mainly against mostly revolves around obesity. Diagnostic screening tests, I think these days they are quite commonly done in the general practice. So stop bang is the one which is mostly recommended. And basically it's very easy. S is for snoring, T is for tiredness, O is observed apneas, and P is treated for blood pressure. And then if you add bang, which is mostly examination, which is BMI of more than 35 kilograms per square meter, age of more than 50, neck circumference more than 40, and gender, which is male, it gives you a pretty good sensitivity of 92%, actually 93% for moderate sleep apnea, and 100% sensitivity for severe sleep apnea. So when we say sensitivity, it's basically just the ability of a test to predict that this patient, if they say there's probability of this patient to have a disease, then they actually have a disease. So if test says it's positive and the actual diagnostic study comes positive as well. So it's pretty high sensitivity for stop bang. And similarly, this is OSA 50 was basically locally designed and validated by one of our colleagues, Tien Lee. And that's OSA 50 is basically obesity with basically here we go for waist circumference in males 102 centimeters and females 88 centimeters, snoring, apneas, and age 50. But obviously you can see that obesity got the most scores 3, and the rest of them would be scores 2. And if you have a score of 5 or more, then the sensitivity again is around 92%. So both of these are pretty reliable screening questionnaires, and you can utilize them. ESS or Epworth is not a screening questionnaire for sleep apnea. It basically just tells you subjectively how sleepy the patient is. It's a good tool if you're basically seeing a patient and you just want to assess are the risk of driving, falling asleep when they're driving or not, or if you're comparing their pre-treatment versus post-treatment basically response, you can use, but obviously it's not the screening questionnaire, validated screening questionnaire for sleep apnea. Diagnosis of sleep apnea is done by polysomnography or sleep study. This is how it looks like. So basically, you have leads attached to your head for EEG, the bands for the thoracic abdominal movement, and then leg leads, single lead ECG, and together, basically, we analyze the data. So on the left is normal sleep study. So at the top is sleep stages, and then you can see on the left is there's quite a lot of REM sleep sections coming up, whereas the REM is in the red. On the right, severe sleep apnea is getting lots of green sleep, which is stage 2 or light sleep. And then these are body positions. Does need to make sure the patient has slept in the supine sleep as well. And here is the main difference. So you see here is pretty clean, and there is less events of hypopneas, whereas here you can see quite frequent hypopneas and oxygen desaturation. So here I'm talking about, basically you can see pretty clean. There's no events here, no desaturations here. This is hypopneas and apneas and desaturation. So there's quite severe sleep apnea and hence leading to less REM sleep and more light sleep, whereas here is seeing much more deep. So this is normal versus abnormal, quite severe sleep apnea, significant desaturation. Nowadays in Australia, you can refer sleep studies directly as long as it meets the diagnostic criteria, also referring criteria, which is basically if they have a stop bank questionnaire, a score of 3 or more, plus ESS of 8 or more, or OSA 50 of 5 plus ESS of 8. So you don't have to go to the sleep physician. You can refer directly patients for a sleep study and take it from there.
Go around the patient. So how would you diagnose those patients?
Yeah,
whether they have the sleep studies or
it's
not?
very hard. I wish we would have infrared, measures to do sleep studies, but it is the problem. So obviously, insomnia usually is diagnosed, clinically diagnosed. Lots of patients have insomnia and sleep apnea together. So that's why the home test is slightly helpful in that way that at least they can sleep their home. But yeah, they have to sleep with the leads on. Even if they get 4 hours of sleep, we say the Medicare obviously asks for 6 or 7 hours of sleep, but even they get clinically 4 hours of sleep would tell us a bit more what's happening as long as they get REM sleep and they sleep on their back. So there is no other way that we can actually diagnose sleep apnea or rule out sleep apnea. There is other ways as well. For example, apnea device, when you just measure the saturation and body movement. And nowadays, actually, lots of apps are offering that, but you don't have EEG. And the same question, particularly, how would you diagnose the insomnia or how much sleep they had or what sleep proportion they have without an EEG? So it's a dilemma, unfortunately. But normally
because they can't get the public CPAP unless they have the proper sleep studies.
Yeah, but if they have insomnia, you would not need CPAP.
No, I mean if they have the sleep apnea.
Yeah.
And if it's not properly diagnosed in the public system or in the private hospital, then they can't access the CPAP. Is that right?
No, at home-based studies they can.
They can.
Yeah,
But they have to pay privately, isn't it?
Yeah, even
I mean, in the public patient, most of these patients, they may not be having a private insurance. So for them to access the CPAP under the public system,
they have to have
have the sleep studies either at the public or the private hospital. Is that right?
No, public funded CPAPs, they have to have a sleep study via public system. So in South Australia, there's LOLMAC and Flinders and QEH and Royal Adelaide, and they are doing home-based studies as well. All of these centers are doing. LOLMAC, no, sorry, my apologies. LOLMAC is not doing, except for them. All the other 3 hospitals are doing. They're doing home studies as well. But if you want a public-funded CPAP, you cannot have a home-based study from any private firm or private hospital and ask for a government funded. So you have to be a public patient in that hospital. So here is what we probably will be focusing on the later half of the talk about. Yes, you have a patient who has sleep apnea, you've diagnosed a sleep apnea. Why you really want to treat them? What if you decide not to treat them or they just go away? Why would you bother about them? So basically, these are the 3 main mechanisms or measures that untreated severe sleep apnea actually causes a problem. So basically, hypoxia and hypercapnia then leads to oxidative stress and all the other problems, of atherosclerosis and everything else. this is one mechanism. The second is there is increased, when you have sleep apnea, you're getting increased arousal index, so your sleep is fragmented, which then leads to increased sympathetic and reduced parasympathetic drive, and then leads to lots of other problems, particularly cardiac arrhythmias. And the third way is during sleep apnea, if it's severe, you have quite low intrathoracic pressure, which again affects on body physiology, mainly atria, and again can lead to arrhythmias as well. So three main ways how it does impact on body physiology and leads to pathology. Hypertension is the most talked about and most known association of sleep apnea since a long time. There's clear evidence that sleep apnea risk is much more higher. So in this study is about 709 subjects, and it's a prospective study, showed the risk of incident hypertension or newly diagnosed hypertension was at about twice in patients with at least mild sleep apnea, and this increased to 3 times in patients with moderate or severe sleep apnea. So, and it's well proven. There is controversies about how much treatment impact is, but there's no controversies about the incidence of incident hypertension or newly diagnosed hypertension. This is just another way of showing association between sleep apnea and hypertension. So this is like not corrected for the age and weight. However, this graph is corrected, and the odds ratio still remain pretty high, approximately 3%, 3 times. So there is quite clear evidence that hypertension, diagnosis of incident hypertension is quite high in patients with sleep apnea. Other risk factor we'll talk about is coronary artery disease and cerebrovascular disease. So basically it's defined as people who had ischemic acute coronary syndrome or myocardial infarction or stroke. And this study showed significantly higher risk of all of these events in patients with severe sleep apnea who have not been treated as compared to those patients who were treated. So even if someone has mild or moderate sleep apnea, they were not treated, they did not have high incidence of cardiovascular or cerebrovascular events, but the patients with severe sleep apnea would. So this graph here is basically on the top. Sorry. So on the top here is we have non-fatal cardiovascular events, which is again, as I discussed, stroke or acute coronary syndrome. And here we have patients which have severe sleep apnea and not treated. And basically the events per 100 was 2.33 as compared to the patients without sleep apnea, which has events of 0.45. Sorry for this graph here. So this is the patients with healthy patients. The risk of having per 100 patients of cardiovascular events was 0.45 and increased to 2.6 in patients with untreated severe sleep apnea. When they got treated, it came very much closer to the normal population. So here we can see approximately 4-5-6 times in higher risk of cardiovascular and cerebrovascular events. This is basically fatal events or deaths, again, 0.3 to 1.0, so 3 times. As we did discuss that obviously if your physiology is disturbed, then there is high sympathetic and less parasympathetic drive. So this study is a sleep heart health study. It was a big study, about 5,000-6,000 people followed for approximately 10 years. And this is the risk of nocturnal cardiac arrhythmias, atrial fibrillation, complex ventricular events, non-sustained VT, bigeminy, and quadrigeminy. And in the white bar, there are healthy people and no sleep apnea, whereas in the gray bars, patients with sleep apnea, significant increased risk for all of these arrhythmias. So basically for AF, 4.8 versus 0.9, they all were quite clinically, statistically significant. Just another way of showing this, the most important is atrial fibrillation. So you can see the odds ratio is 4.0. So odds ratio basically is just trying to show the association between the two events. So the event associated between AF and severe sleep apnea is 4 times basically. As we'd already discussed, strong association in terms of the dangerous cardiac arrhythmias is atrial fibrillation is very well established. Nowadays, there's new trials which have shown that people who get recurrent atrial fibrillation after ablation or cardioversion, there's some evidence that atrial fibrillation may be the underlying culprit, and I'm pretty sure Dr. Coker will talk more about it. So you don't need to be a genius to think about that if patients are having all of this extra risk of cardiovascular events, then you would be at higher risk of cardiac death as well. Basically, the risk of cardiac death, sudden cardiac death at night time goes up by 3-folds in patients with untreated sleep apnea, and their all-cause mortality also goes up. So basically, this is a meta-analysis of the patients and the studies in North America, Asia, and Australia. And on the left is basically the patients, normal patients. On the right is sleep apnea patients. You can see hazard ratio, or the proportion between the two groups is much more higher, 1.7 times of overall mortality in patients with sleep apnea as compared to without sleep apnea. And actually, Australian data was pretty scary as 6.24. Diabetes and insulin resistance, I probably don't have to go a lot into the details, but there is increased evidence that patients with untreated sleep apnea have much more higher insulin resistance, even after comparing or after getting the confounding obesity out of proportion. And there are associations, for example, high cholesterol and oxidative stress. There's quite significant evidence, growing evidence that it does impact untreated severe sleep apnea, does have impact on these parameters as well. Just very briefly, this study about the sleep apnea treatment and metabolic syndrome, they basically randomized and crossed over all the patients who were going through their sleep lab and who were diagnosed with moderate and severe sleep apnea, but excluded patients who were already on antihypertensives or already were treated for diabetes or cholesterol, so pretty much just sleep apnea patients, and then crossed over them with CPAP and sham CPAP. Sham CPAP basically just to randomize, just to blind them that they think they're having a treatment, but they see they did not have the treatment. And the patients with sleep apnea had significant reduction. The patients on CPAP or treating sleep apnea had significant reduction in their systolic and diastolic blood pressure, their HbA1c, and their total cholesterol. So basically, quite significant reduction in all of these parameters of metabolic syndrome after treatment with CPAP machine. So the other reason that people die from sleep apnea, apart from the cardiovascular problems, is death on the roads.
Una mattina mi son svegliata, oh bella ciao, bella ciao, bella ciao, ciao, ciao. Una mattina mi son svegliata, con l'invasor, partigiano, portami via, oh bella ciao, bella ciao, bella ciao.
Zobuďte sa, vyberte si najvýhodnejšie povinné zmluvné poistenie.
So there is clear evidence up to the risk of road traffic accidents in patients with sleep apnea. Severe sleep apnea is up to 3 to 4 times, and it's a real risk. In addition, there is more research growing, particularly in geriatric population, about their neurocognitive decline, which is disproportionate to the degree of dementia. That sleep apnea is usually a contributing factor, so we need to be aware of the space in that field. You want a question? Sorry? Time, just 2 more minutes. I think we don't have the fourth speaker, so it's coming. Okay, all right. Okay, so in terms of the management, lifestyle management is the way to start with. Doesn't matter whether a patient has mild, moderate, or severe sleep apnea. Lifestyle, obviously, Tien has talked more about it, so I'll just move forward. Weight loss is very important. Weight loss from the baseline of 10%. 10% baseline would have about 26% decline in AHI. CPAP is the gold standard treatment for severe sleep apnea. You don't have to put every patient of yours who's been diagnosed with apologies of CLM sleep, but you don't have to put everyone on CPAP. So if patients have severe sleep apnea, they are symptomatic, they have significant cardiovascular risk factor, yes, CPAP, but if they have mild or moderate sleep apnea, you can give them a choice. Weight loss, lifestyle modifications, MES, or ENT intervention. Though still, if you compare, CPAP has the highest success rates for improvement of symptoms. So symptoms-wise, you would see the greatest difference, daytime sleepiness, cognition-wise with CPAP as compared to the splint or the ENT intervention. But if someone is not able to tolerate CPAP, you don't have to push them for it because that's fragmenting their sleep more. So I'll just skip all the other things because I just summarized here. So CPAP is the gold standard treatment, mainly works for sleepiness, but also but if you have a truck driver, obviously you need to push them much more harder for CPAP machine because the ENT intervention or splint would not be as effective. So I'll just skip through these things. And just the take-home message is obesity and sleep apnea are the most common problems likely to be encountered in general practice. Severe sleep apnea is a marker of increased cardiovascular and metabolic associates. Obesity and sleep apnea, this is a new field of research. Basically, there's a bidirectional relationship. It's very commonly known that obesity would cause sleep apnea, but now there's some evidence that having sleep apnea would also cause rapid weight gain because arousals will lead to some changes in appetite center and their eating preferences, and hence it just initiates more rapid weight gain and sleep apnea. So if you have a patient who is obese and have sleep apnea, just don't put them on CPAP machine and forget about it. You have to push for weight loss as well because you would not be able to achieve optimal cardiovascular outcome until they have losing their weight. Thank you very much. So you're talking about a download they bring, the CPAP treatment one? Or you're talking about the patients already on CPAP, they bring their app?
They're already on the CPAP, and they bring the app, and they're like, just
Absolutely.
have a look.
So you have to look at three things.
Okay.
So one is basically what's their usage like. So if their usage is coming at least 5 hours, so you can look at day by day, or you can go on the app and ask them to generate a summary. But looking at average usage of at least 5 hours for it to be beneficial for symptomatically and from cardiovascular perspective. Second thing, you look at AHI, again, rule of 5. Ideally should be less than 5 on an average. But if they're getting achieve less than 5 or most of the nights, and one night it goes up to 8 or 9, it's not a major deal. So rule of 5, usage should be more than 5 hours on an average. Usage, AHI should be less than 5, and then mask leak. So if you're seeing a mask leak for only 10 minutes or 15 minutes, that's not too bad. But seeing a mask leak of 1 hour or 40%, then they have to get either pressure reduced or get their mask refit. So these three things, basically. Nice.
So we'll do the questions in the end, please. At the panel discussion, yep.
Thank you.
Thank you. Thank you, Dr. Usmani, for providing us with your expertise. I believe Dr. Adam Nelson is here, so we would like to invite him up onto the panel as well. So our next speaker is Dr. Kashif Khoka, who will be discussing obesity and atrial fibrillation. Dr. Khoka joined SA Heart Adelaide in 2019 as a cardiologist and electrophysiologist. His area of expertise includes arrhythmia management, hypertension, and cardiac devices. He completed his training in cardiology and electrophysiology at various institutions in the UK, New Zealand, Australia, including Adelaide. He has extensive experience in managing cardiac arrhythmias and is involved in multiple research projects focusing on atrial fibrillation. Dr. Khoka has authored over 15 manuscripts in peer-reviewed journals and is a co-investigator of multiple prospective trials. His research focus includes studying the impact of CV risk on development of atrial fibrillation and the role of physiology, left bundle pacing in prevention of pacing-induced heart failure and AF. Welcome, Dr. Khoka.
Thank you for the introduction, and I'm really glad to be here spending my Saturday afternoon with friends and colleagues, so thank you for the invite. Now, a couple of things. I'm one of the electrophysiologists, and I'm almost 8 years in Adelaide now. So compared to the other speakers, I'm a teenager. And those of you who are waiting for lunch, I'm the second last man standing, so bear with me. So the topic is very pertinent, obesity and atrial fibrillation. I think Adelaide is very relevant in terms of obesity and atrial fibrillation. During my PhD time in University of Adelaide, I was part of the group with Prash Sanders, and I think he was one of the pioneers who bring out the important work and publish that to compare the different analogies and how we're going to tackle obesity and how we can improve AF outcomes. So cardiovascular risk modification with a special focus on obesity, I think if I'm fair to say it's an Adelaide child. And I'm glad to say that this has made its way into the guidelines we were tackling atrial fibrillation. So we all know about obesity. As per definition, any BMI of 30 or above. It's a substantial accumulation of body fat impacting on health. I like to see obesity as a chronic inflammatory complex problem, as most of the other speakers have alluded to. And it's potentially it's a brain disorder, it's a metabolic disorder as well. You know, you start eating something and it has the right ingredients of salt, sugar, and fat. And it's telling your buds that eat me and I'll make you stronger. And it go to the limbic system, stimulating all the arcuate nucleus and establishing those memory pathways. And you can't really stop eating and you keep on eating, and how does the whole process is. So look at obesity in a different way, and as other colleagues of mine have alluded to, it's not only about the weight. It's potentially there's something in the brain as well, and behavior modification, so on and so forth is a part of it. We know it's a significant morbidity issue and mortality issue associated with obesity as well. There are 13 different cancers. We know there's association with obesity, and more than 200 health conditions. We all know about the metabolic syndrome. There are criteria, and any three among these 5 criteria as per definition will categorize as metabolic syndrome, a waist circumference of more than 40 inches in men, more than 35 in female, in inches, blood pressure over 130 by 85, fasting, high triglyceride levels, and low HDL and high sugar levels, but not in the diabetic range. This is to show the actual prevalence, and that's the US data. So red is bad. And you can see that over the years, the BMI of 35 is getting worse. And although we haven't got Australian data, but I wouldn't be surprised that if we are heading towards that. So it's as I said, it's almost an endemic, and AF and other problems associated with obesity is going in the same direction. Now, we're not really sure about the actual causation data, but we know people who are obese, as far as the prospective data is concerned, not in randomized trial, there's an association of atrial fibrillation with obesity. And these are a number of studies, as you can see, published from 2004 up to 2017, clearly indicating there's an association of atrial fibrillation with obesity. Some of this US, some of this Korean data, and also from Scandinavia. But all in all, if you see that obesity with a BMI of more than 30 increase the hazard ratio by 1.3, 1.4. So relative risk of 30-40% of having atrial fibrillation. Now, I have to define atrial fibrillation as well, because just to keep things in perspective. So normally 4 chambers of the heart. Let me see if I can use the pointer. Sinus nodes at the right top chamber, send electrical impulse through the AV node to the bottom chamber. Usually the process starts, as we know from the study published by Michelle Hezuger in 1999, New England Journal of Medicine. These veins, which are draining blood from the lungs into the left top chamber, when the left top chamber start getting stretched, and these muscle fibers, they start getting wrinkly, they go through the age-related changes. That triggered extra beats from these pulmonary veins, which kind of goes into this wrinkling part of the chamber and start perpetuating, resulting in abnormal racing, which is called atrial fibrillation. Now, we know AF is a disease of elderly. If someone in the year of 8 years old or octogenarian, at least 16-20% of them have atrial fibrillation. However, if someone have those metabolic syndrome features and obese, the fat sits at the back of the left top chamber, one of the mechanisms, and have a paracrine impact, resulting in accelerated process of aging, cause accelerated wrinkling, and that wrinkles basically irritate these muscle fibers and trigger these extra beats initially through the pulmonary veins, and later on, down the line, when the disease turns into a substrate where the atrial atria get more fibrous and scar, then that keeps on perpetuating, and that goes around resulting in atrial fibrillation. Now, definition of atrial fibrillation is based on time. If the episode terminates spontaneously or within 7 days, as per American Heart Association guidelines, we call it paroxysmal AF. If it's more than 7 days or it requires cardioversion or some intervention, it's persistent AF. Long persistent AF is continued for more than 12 months, and chronic persistent or permanent is more than 12 months. Now, this definition also tells us about the underlying story, what's happening to the atria at the same time. Because if atria has a lot of wrinkles and scar in there and it's remodeled, it will potentially result in more persistent form of arrhythmia. And the outcome of any treatment, including risk factor modification, medications, intervention, obviously will not be as good as compared to a more paroxysmal form with relatively normal LA volume as we see. We know the AF is, the burden is increasing as well. So this is the Australian data, which was published by Celine in February 2019 in the Heart Journal. So the bars here showing the orange bars are the heart failure and the blue bars are the atrial fibrillation. And you're clearly seeing that the AF incidence is kind of surpassing heart failure. And that previously in my slides, I've also shown that this is an endemic problem, and we're going to see more and more atrial fibrillation in coming years as the metabolic syndrome and obesity is getting more prevalent. US data, almost the same. It's going to be double the incidence of atrial fibrillation in next few years. At the moment, they're saying 3.3 million individual, but that's on its rise. Why this is important? Because let me introduce you to another concept, because left atrial myopathy or atrial fibrillation is potentially an indicator, a marker of the other disease processes happening. And we know that because prevalence is going up. It is associated with risk of death, almost twice the risk of death. It's 50% of heart failure patients, they have atrial fibrillation. And now we're seeing that more and more heart failure hospitalization, at least 40% of them is attributable to atrial fibrillation. It's also impact on the cardiovascular events. 1/3 of the stroke patients have underlying atrial fibrillation. As I said, it impairs quality of life, and we do see at least 1/3 of the patient presented with rate-related cardiomyopathy, so AF impacting on their LV systolic function. Now, what are the major cardiovascular risks which are associated with atrial fibrillation? Yes, it's an age-related issue, and probably we, as the population is aging, we're seeing more of atrial fibrillation. But we know from the studies, heart failure, valvular heart disease, hypertension, and last but not the least, obesity is adding into that list of risk factors, which is really increasing and pushing the incidence of atrial fibrillation further. What is the possible mechanism of obesity as a risk factor for atrial and ventricle remodeling resulting in arrhythmia? Again, it's a paracrine impact, and it's also a systemic impact as well. As I've earlier mentioned, that the fat sits at the back of the left atrium, so it's an epicardial adipose tissue, and it has a paracrine impact with increase the inflammatory response, increase the oxidative stress, and that results in accelerated process of aging. Now, you do have a bit of a cardiometabolic disease load as well through dyslipidemia, impaired glucose tolerance, hypertension, increasing the oxidative stress, again, triggering all these chronic inflammation processes. With sleep apnea, just Dr. Usmani has alluded to that how common sleep apnea prevalence is, and those hypoxia and oxidative stress all accumulating, resulting in remodeling of the atrial and ventricle tissue, and that potentially accelerates the process of aging, scarring, and resulting in more permanent or form of arrhythmias. Particularly, as I said, there's an underlying arrhythmogenic mechanism, and epicardial fat will keep on coming there, and I've alluded to there are systemic factors which going to trigger the inflammation, oxidative stress, and change in the ganglion response. So dysautonomia, we do see it, that how the adrenaline and noradrenaline or the vagal interaction happens, and that results in electrical remodeling first. So a person coming in with some risk factor with paroxysmal AF, potentially the process has already started, although in the echo we're not seeing that the left atrium is significantly dilated, but they have electrical remodeling where we do see a conduction in the atria is getting slow or heterogeneous, and that potentially facilitating that re-entry circuit, which happens in atrial fibrillation. And later on, as they develop the scar due to results of unattendance risk factors, including those metabolic syndrome, the AF incidence, and the more severe form of disease will happen. Busy slide, but again, particularly looking at the electrophysiological point of view. Someone have genes. They have triggering the environmental factors, including metabolic syndrome. And to begin with, they will have more pulmonary vein-induced triggers, because when the stretch happens, the pulmonary veins are the one to trigger the episode of atrial fibrillation, because the actual atria hasn't scarred yet. And we start seeing this electrophysiological changes. Early after depolarization, probably you remember your action potentials. So some of these scar-related changes, they start getting delayed in that action potential in particular components, and that results in re-entry circuit, which are very focal, local, involving the pulmonary veins. But later on, as the disease more established, you have this kind of scar involving the actual chamber with the substrate, and you see more severe form of disease or atrial fibrillation, which is persistent and chronic persistent. So the whole idea of this is that if someone have risk factors and coming in early with a paroxysmal AF, send to the appropriate team with a multidisciplinary approach early to prevent this significant scar pattern happening in the atria, which is a kind of a more late form of disease, and the outcomes obviously will not be as good as compared to the more earlier forms. Now, coming back to the metabolic syndrome and component on risk of atrial fibrillation. So the top bar, the graphs in red showing the individual components of the metabolic syndrome, and clearly blood pressure kind of stands out there. And if in the blue kind of bars, you can see as the metabolic syndrome components accumulate, the atrial fibrillation incidence goes up because the hazard ratio is 1.6 or so. So this is a Korean data, again, not a randomized trial, but prospective study. And if we see, so what they've done very cleverly, they look into percentile, the same Korean data, and they say the people who are in their higher percentile towards the metabolic syndrome, increased waist, and also impaired fasting glucose, etc., their incidence of atrial fibrillation is much higher as compared to the others, so the higher on the percentile on your end, the more components of metabolic syndrome a person has, that's again will facilitate remodeling of the atria, which is the indicator of this aging process in atrial fibrillation. There is a bit of gender discrepancy, and we're not sure why. So the graph on my right is male, and the graph on my right is the male, and the left on the females. And you can see with the aging population, the green bar here, the more metabolic syndrome components a male have in their 60s and 69, they're more likely to present with atrial fibrillation. So there is a bit of genetic predisposition as well, and we do see racial discrepancies. Now, if we leave things unattended, a person starts with lone atrial fibrillation, they don't have any known risk factor, and then if we leave things unattended, they gradually turn from paroxysmal to more persistent and then permanent form of atrial fibrillation, especially in case of unattended cardiovascular risk. So they go through this aging process more quickly. So if a person who is presenting with atrial fibrillation at the age of 80, If they are coming in early at 50 with risk factor, you leave them unattended, their heart will go through the aging process quickly. So again, prevention early and sending to the appropriate team is important. Now, from the studies, what we have seen that a patient who have high prevalence of non-pulmonary vein triggers, one of the markers where the actual atria is firing is the pulmonary veins are getting more silent, and that's an indicator of fibrosis in the left atrium. Someone who have more severe form of disease or persistent atrial fibrillation, low ejection fraction, severe left atrium. I think this is one of the features we see on echo. And I usually like to see the left atrial volume. I don't believe in left atrial dimensions only. And that's a slightly better indicator. If someone has structural heart disease like cardiomyopathy, hypertrophic cardiomyopathy, valvular heart disease, we do see significant fibrosis and more severe form of atrial fibrillation. And some of these risks are not reversible. For example, you can't reverse hypertrophic cardiomyopathy fully, but sleep apnea can be treated. We can do something for obesity. Age, we can't do much. Gender, we can't do much about. So we look into reversible factors and try to tackle them early to change the course of the more severe form of disease. And that's almost the same thing. So this is a study published by Utah Group in North America, and they look at the atrial fibrosis percentage. So the blue is the normal tissue, and the green or the yellow is the amount of scarring. So they staged the scarring according to the severity as shown in the colors and classify them at stage 1 to stage 4. And the bars are showing that the persistent is shown in black, and the paroxysmal AF, or the more, you can say, lighter form of the disease, was shown in gray. So stage 4, when there's established scar and significant scar, you can see at least 75% of these patients present with the persistent form of the atrial fibrillation. So if we deal with those risk factors and robustly modify them early, probably we can prevent it or slow the progression. So it's a complex slide, but it's an interaction of substrate and triggers in atrial fibrillation. And this is an animal model of a left atrium. And there are a lot of factors as shown in orange, which potentially cause aging or early scarring or remodeling. And there are a few reversible factors which we can instigate, or the patient can instigate, try to improve the outcome. For example, obesity, smoking, impaired glucose tolerance. We can't do much about the aging, but certainly exercise improvement and reduction in calories intake will help improve the outcome. And I'll show you some slides in probably a couple of slides with why this is important, especially the weight. This is an elegant study. It was performed in Adelaide by Dr. Mahajan. It's one of his PhD projects. It's an animal study. So what he did, we first fed the animals so they become obese. And then we look at different aspects. So the body fat is being checked through a DEXA scan, and you can see the lean was shown in green, blue. And the red, you're seeing the animal, which is gain weight. And then the third one is the 30% weight loss among those cohort. And then we look at the LA pressure, conduction velocity. That means the markers of the left atrial remodeling electrically. Also the fibrosis. And what you can see that obviously with increasing fat or obesity or weight, all of these electrophysiological markers were getting impaired. But the good news is, once they start losing 30% of their weight, these markers, as shown in black here, they started improving, which is kind of encouraging. So if we do something about this obesity-related electrophysiological and structural changes in the left atrium early, then probably we can reverse the process to a degree. So from the same study with the slides, and you can see the lean controls at the far right, obese animals. So this is a left atrial biopsy and staining. And if you look at these small vacuoles here, the white part, that's the fat invading the left atrium here. So as I mentioned earlier, that the fat, epicardial fat, sit at the back of the left atrium. It's actually caused fibrosis, as shown down here as well. And those animals who have lost 30% of their body weight, you can see the fibrosis is reversed and it's almost going back towards normal. So that's an encouraging sign as well, that if we tackle the weight problem early, the actual remodeling of the left atrium is reversible. Obviously, you can't prove it in human because you can't take biopsies like that. So this leads to the risk factor modification clinic and approach, and we started performing those weight loss clinic with a comprehensive approach of asking one of the endocrinologists, exercise physiologists, and the whole obesity management program in the group. And we do see that with weight loss, we have some changes, electrophysiological and structural changes in the atria, which results in better outcome. And this is the proof, the Legacy and ARREST-AF study. Now the bars are showing on the top, red is the people who have risk factor modification and lost more than 10% of their body weight and maintain it for 12 months. You can clearly see their incidence of AF and recurrence of AF is much less as compared to controls or people who were left alone without any weight loss. So what are the proposed mechanism of, there's another entity, we're probably looking at obesity-induced cardiomyopathy. So it's probably a common feature in hypertension, dyslipidemia, metabolic syndrome, diabetes, all these chronic inflammatory processes with adipocyte paracrine impact on the epicardium, with sleep apnea, oxidative stress, and those metabolic and neurohormonal triggered activity resulting atrial remodeling with fatty infiltration, fibrosis, and conduction issues, which results in atrial fibrillation. Obesity also causes a slight increased volume, increase the left ventricle strain, left ventricle hypertrophy, and we're also seeing lots and lots of patients with heart failure with preserved ejection fraction, and it's a common entity. This is an important slide. I think that's, they said the aggressive cardiovascular risk factor modification is the key in atrial fibrillation patient, and it's not only the weight. Because a lot of the studies, a prospective thing we're seeing is not the weight, as my previous speakers alluded to as well. So it has to be a comprehensive approach. We target our patients to lose more than 10% of body weight with a BMI target of less than 27. A dietitian has to be involved with a dietary plan, their activity levels, and they should be educated and encouraged to increase their activity levels. So more than 200 minutes of exercise per week. Encouraged to keep a blood pressure diary, and we do perform exercise stress tests to look at the blood pressure response of more than 200 millimeter mercury at peak exercise. If that's the case, we like to treat it early. Blood pressure, we target less than 130 by 80. If someone have a sleep apnea with AHI index of more than 30, strongly encourage them to take CPAP. If it's more than 20 with resistant hypertension, I still encourage them to take CPAP. And obviously, it's been diagnosed in an overnight sleep study. Stop smoking advice, reducing their alcohol to maximum 5 standard drinks a week, dietary changes. And it's a kind of the actual concept was it's a nurse-led multi-system, multi-team involvement, endocrinologists, GP, electrophysiologist, and we've shown, especially in Legacy and Reverse AF, that the outcome improves from them once they start hitting their risk factors aggressively. Now, what are the obesity treatment we have, and whether any of them have any impact on the atrial fibrillation? The answer is we are not known yet that any of these obesity treatment have a real impact on atrial fibrillation. And obviously we have few medications starting from phentermine, which is available since 1959. But towards the lower part of the table, semaglutide, liraglutide, and tirzepatide I think I'll be very keen to see the evidence coming out. What's the impact of weight loss through this medication or bariatric surgery? What's like on the incidence of atrial fibrillation and the recurrence? We know that the percentage of weight loss with lifestyle intervention is roughly 5 to 10%. Medications improve it to 15-20%, especially with these new GLP antagonists. But the bariatric surgery is the winner so far, which also has shown cardiovascular events improvement as well. And the graph you can see is kind of after a year of bariatric surgery, you can see their graphs are kind of moving apart. And for the people who are obese and have the bariatric surgery, in terms of composite cardiovascular events, they do better. But again, we have very little data on atrial fibrillation. Potentially, these new, novel, highly effective gut hormone-based anti-obesity therapies maybe they have an increasing role in preventing atrial fibrillation and atrial cardiomyopathy, but the jury is out. So this robust cardiovascular risk modification, including weight loss of more than 10%, so it has made its way into guidelines, and now it's recommended in AF patients to improve outcomes. So ladies and gentlemen, I would like to conclude that obesity is a chronic, complex, multi-system disorder that do cause compensatory cardiovascular adaptations and culminating in electrophysiological remodeling, changes in atria and ventricle, and it increased the incidence of atrial fibrillation. Epicardial fat, paracrine impact, and a generalized metabolic load is the potential driver. And yes, partially it's reversible. We do see a change in trajectory of the atrial fibrillation outcome in established patients, but whether the incidence of the atrial fibrillation will go down by managing the risk and losing weight, the jury is still out. So thank you for your attention.
Thank you for that very comprehensive presentation. In regard to our participants on Zoom, we're very happy to have you here today and delighted by your participation. If you have any questions, please post them in the Zoom chat and we will endeavour to get the presenters to answer those. So now I introduce Dr. Adam Nelson, our next speaker, who will be speaking on metabolic syndrome and dyslipidemia, particularly non-statin therapies for lowering LDL-C. Adam Nelson is an early career interventional cardiologist at the RA and QEH, has academic and clinical interests in cardiometabolic disease and implementation science. He serves as the clinical lead on several national and international trials aimed at improving adherence to clinical guidelines and the adoption of established and emerging cardiometabolic therapies among patients with diabetes, dyslipidemia, and overweight or obesity. Please welcome Adam.
Thank you for the kind introduction. Great to be here with you today. Abdul, thank you for the invitation. Fantastic program, the sponsors for supporting it. I think you've been sitting for almost 2 hours, so just take a moment just to stand up, everyone stand up, and just sort of stretch your legs. I'm going to give you 30 minutes of a whirlwind tour of lipids, and I want all of your attention. So, all right, have a seat. Very good. It's kind of a tough room here, I don't quite know which way to stand. Sorry I couldn't be here a little earlier. I'm one of the few with a first aid certificate in my son's under-7 football team, so I was having that duty today, and I must say I feel much more comfortable talking about lipids with you than I do musculoskeletal injuries of 6-year-olds, so pleased to be with you today. My talk was around sort of metabolic syndrome beyond statins, LDL cholesterol. Now that could be a 3-day symposium, so I'm going to speak to mainly LDL cholesterol, but happy to be drawn out around triglycerides particularly, which speak to the metabolic syndrome particularly. But today's really more about LDL cholesterol, and I think is really the cornerstone of how we manage patients with elevated cardiovascular risk. This summarises my disclosure. I enjoy working with industry. I find that it's easy to work with everybody and then you don't become conflicted if you work with everybody. Outline for my talk today, I've got 3 main points. Number 1 is going to be that LDL cholesterol remains causal, cumulative, but ultimately very modifiable. Number 2, we're going to talk a little bit around unmet clinical need and the exciting opportunity we have for RNA therapeutics. I'll touch a little bit on inclisiran and a bit looking forwards to what's coming down the pike around novel agents. And number 3, critically, is how we as a clinical environment overcome inertia, which plagues so much of how we struggle to manage patients with elevated cardiovascular risk. There we go. I can't give a lipid talk without putting this slide. This is the summary of almost 30 years of statin era data showing us this beautiful linear relationship between achieved LDL cholesterol on the x-axis and events on the y-axis, whether you're in primary or secondary prevention, primary dark blue diamonds and secondary light blue squares, very clearly showing that what you end up with on LDL cholesterol relates to your incidence of cardiovascular events. What's really neat, this is data summarised from Michael Silverman, a fellow at Boston at the time, who said it didn't really matter how you got there. So this is really neat regression analysis showing that whether you had a PCSK9 inhibitor, a statin, had ileal bypass, NICE, and even at the very lower ends of LDL-C lowering, that linear relation holds. The mechanism of action is completely independent of how we achieve that reduction in CV risk. And this is one of my favourite slides around this entire space. Again, linear relationships I'm presenting you. What is very different here is the duration of follow-up. So here you can see in the red are the randomised controlled trials of the therapies we have available to us for LDL cholesterol lowering of a median duration of around about 5 years. You can see then moving up, we have the prospective cohort studies in grey, median duration 10 to 12 years. And then at the top there, you can see Mendelian randomisation, data that we have from really neat natural assortment studies of almost 50 years duration, lifetime exposure to varying levels of LDL cholesterol. Again, linear relationships, but what you can appreciate there with 1 millimole reduction, that you can see there in the middle, that vertical line, you can achieve between 20 and 25% relative risk reduction for further ASCVD risk in patients treated for 5 years. You go up to treat for 10 years, we're talking like 30 to 35% relative risk reduction. Then you go to lifetime exposure to lower levels of LDL cholesterol, almost 50% reduction. Completely throws out our entire way in which we treat this condition. Why turn 50, suddenly get a PSA, worry about your blood pressure, worry about your cholesterol? We know fatty streaks occur in your 30s. We know that from autopsy studies of patients who die of non-CV death, we see early changes in 30s and 40s. Completely changes our entire way to think about this almost around LDL cholesterol years. A bit like we talk about pack years with smoking. Here, if I'm much more worried about my patient in clinic who sits in front of me age 40 with an LDL of 4 than I'm about 75-year-old Doris who's got an LDL of 4. The entire exposure of a lifetime is so much more important around LDL cholesterol. So what data do we have in a prospective way to try and unpack that? I was very fortunate to be in the audience when Mark Sabatini presented this work. This is Furia, this is evolocumab, Repatha, administered two weekly or monthly in patients who were pretty well treated at the time. Statin, some ezetimibe use based on LDL of 1.8 millimoles per litre with established disease, and they were randomised to evolocumab or placebo. And you can see there on the right, the curve started to separate around about 12 months. And there's this tantalising suggestion that potentially if we treated patients for longer, we might see them shift CV death. Needless to say, this was sufficient for us to prove the hypothesis that, again, if you are lower LDL cholesterol for longer, you do better. But what was even neater was they then went on and did an open label extension or an OLE study where patients were invited of that parent trial, 27,000 individuals, around 6,000 agreed to continue on evolocumab for a further 5 years, allowing a median follow-up for some patients of in fact closer to 7 or 8 years. As you would expect, patients treated in placebo here in blue have profound reductions in their LDL cholesterol once they're subsequently treated with evolocumab. What was really neat to see in this study is that patients treated with evolocumab from the start there in red continued to sustain the benefits of evolocumab. There was no diminution of effect. The LDL cholesterol lowering remained the same for out to 5 years. Again, reductions here in the order of 50 to 60% from baseline. This is a post hoc analysis from Prakriti Gaba, who's a fellow at Boston at the moment. She neatly showed in patients who achieved lower levels of LDL cholesterol, again, lower levels of ASCVD risk. This monotonic relationship here between achieved LDL cholesterol, less than 0.5 millimoles per litre there in red, lower levels compared to those at 0.5 to 1, 1 to 1.4, and greater than 1.8. This really neat suggestion that the modelling data plays out in prospective clinical trials. Probably the most common question I get when I see patients referred in whose LDL is below 1 is it safe? Well, we've got really neat Mendelian randomisation data for patients who have been lifelong exposed to very low levels of LDL cholesterol and they have longevity and resilience from ASCVD. But this is neat data. This is a Cambridge questionnaire from the Ebbinghaus subgroup of the Fourier study, which showed that patients had no change in their executive functioning over time, certainly no issues around this foggy head or cognitive impairment that patients can mention. In fact, we can probably see that potentially some benefits, and we'll see that with this a really neat statin trial that's currently recruiting called Preventable in older patients to see whether statin therapy improves cognitive function. So I've presented to you longer, lower and earlier in terms of the sort of more chronic patients. We've got really neat data now looking at patients who have got a fresh ACS. This is data presented from Steve Nichols, who you will know, Australian, a giant in the space, took patients who were admitted with NSTEMI, had an angiogram and had a non-culprit plaque, had an OCT done, and at the OCT they showed evidence of vulnerable features, a thin cap fibroatheroma, evidence of a large lipid arc. And they randomised those patients to receive, on top of standard therapy, this is statins, ezetimibe, evolocumab or placebo, and they repeated the study. What was really neat, and again, if you don't see OCT frequently, this is what OCT looks like. We always put the best looking pictures in the figure of the paper. But you can see in the top left there, if I can convince you that that bright arc is slightly thinner in that top left quadrant than it is in the bottom left, in the sort of bottom left quadrant, but in the same sort of dotted area, is the thickening of that cap to suggest that we're turning plaque off and making it more inert, less likely to have a further ASCVD event. And you can see in this continuous lowest plot there, achieved levels of LDL cholesterol relate inversely to thickening of the fibrous cap. The lower you can get your LDL cholesterol, the thicker you have your fibrous cap, the less likely you are to have spontaneous MI. Really neat data translating these observations we've seen from the clinical environment to reduce CV events. We actually achieve that at the plaque wall, at the arterial wall. Patients sit in my clinic and look very blankly at me when I talk abstractly about what LDL cholesterol levels mean. But if you show them what it looks like in their arteries, and I very frequently bring up their CT scan and show them there's rust in these arteries, we've got to work on this. I don't really remember that Quitline ad on TV where they took an autopsy and they sort of squeezed out plaque like a toothpaste. I mean, we all know that doesn't actually happen, but the visual of that was really potent. Here you can see patients with a vulnerable plaque, a large lipid pool, macrophages, cholesterol crystals, evidence of pro-inflammatory milieu. And when you reduce LDL cholesterol profoundly, we see in the Glagoff study a reduction in the lipid pool, a thickening of the fibrous cap, and we tell patients we can turn their plaque off. Now, no crystal balls, patients still continue to have events, but at least we can show them why they're on all these therapies. So accordingly then, it would make sense that in patients who have highest atherosclerotic cardiovascular risk, we have the lowest LDL treatment targets and the most intensive regimens. Unfortunately, the Australian guidelines are almost 10 years out of date, and the AusCVD risk calculator for primary prevention does not talk about LDL cholesterol levels. So we look elsewhere. This is the European guidelines. I think it's the best diagram that exists in either the ACC or the ESC guidance in this space. You can see at the bottom right quadrant, those at very high risk, those with established ASCVD or those with imaging evidence of atherosclerosis have got the lowest treatment goal of 1.4 millimoles per litre. And if you're starting north of 3.5 millimoles per litre, you're going to need to be on more than one drug to achieve that. Similarly, the corollary then means that those who have the lowest absolute risk in the top left quadrant with the lowest risk of ASCVD have more permissive targets. The question there is the juice worth the squeeze? Patients who've got a 5-year risk of less than 3%, reducing it by 25% relatively speaking, again, is fairly marginal. So I think that's where it's a really nice discussion we can have with our patients around this risk treatment. This is some data we did in the US, which basically shows the challenges we have around inertia. This is a summary of patients that we took from an insured population in the US, patients with established ASCVD. And on the right, you can see the patients, or the proportion of the cohort in green on high-intensity statin, the proportion in yellow on intermediate-intensity statin or low, and the proportion in red on no statin at all. Alarming data, a large proportion are untreated. But what's more alarming is that very few patients move between red to yellow or yellow to green. We're very set and forget when it comes to cholesterol lowering. We don't reevaluate how patients are achieving their goals. This is data from the Da Vinci study in Europe suggesting that the US is not just bad by itself, we're all actually similarly underperforming. This is looking at a registry of participants with established ASCVD across Europe. You can see the hollow bars represent patients achieving a goal of 1.4 millimoles per litre, the contemporary era goal, and those in the solid bars representing the proportion of patients achieving the more permissive later goal of 1.8 millimoles per litre, around about 40% achieving 1.8 millimoles per litre there on the top, only 1 in 5 patients achieving a goal of 1.4 millimoles per litre. It makes sense. As you move the goalposts further and further along, unless we intensify therapy for our patients, we're going to leave them behind and leave them with untreated residual risk. You and I all have conversations like this in the clinic. The challenge is that statins remain the most effective, cheap, easy, well-tolerated way to lower LDL cholesterol. But the data shows us that by 20 months, patients with established ASCVD, patients are no longer taking their statins as prescribed. And you and I can sit there till we're blue in the face telling them to take their statins. If they're not taking them, they're not deriving the benefit from them. So we need additional therapies because patients continue not to be able to take their statins for a variety of reasons. Not one bad patient, not one difficult clinician. Lots of reasons why these medications fall short. So I've told you a little bit about LDL cholesterol. I want to talk to you a little bit more about unmet clinical need. And I think the challenge here is that, as I've mentioned, statins remain the cheapest and most effective way of doing it, but adherence limits our ability to achieve that. And we know from a population health strategy perspective, over-medicating patients is a real concern, and that there is a need for us to look at lower touch ways to achieve LDL cholesterol lowering, and there are a lack of therapeutic agents in this space. I could give an entire seminar in this space, and so I need to just contain my enthusiasm a little bit, but RNA therapeutics are here. Antisense oligonucleotides have been around now for some time. This is using a 15 to 20 base pair that binds within the cell to this thing called RNase H1, and that in itself, the ASO is a complement. This is Watson-Crick base pairing, binds to the target RNA, mRNA, and when you bind the target mRNA with RNAs attached, you then degrade the mRNA. You remove the recipe book for the protein. Similarly, small interfering RNAs use the same type of process, slightly larger. These are double-stranded, and what they do is once they enter the cell, we'll talk about this a bit more with inclisiran specifically, they then separate into guide and passenger, and the guide strand then binds in a complementary way to the target mRNA and is brought down through this RISC, the RNA-induced silencing complex. This is natural cell architecture that we're using. We're just specifying it with respect to a particular protein or target or receptor. So how does that play out with inclisiran? Inclisiran looks, for all intents and purposes, like Prolia. It's the same sort of injection hardware. So inclisiran is this double-stranded molecule that's bound to GalNAc. GalNAc is this triantennary feature, this orange, that binds with exquisite specificity to the ASGPR, or the azioglycoprotein receptor on the hepatocyte. Exquisitely expressed on the hepatocyte, very selective mechanism of action. That GalNAc binds beautifully to that, meaning that there is very little off-target effects of inclisiran. Once it then binds to the ASGPR, it can then be internalized into the hepatocyte. Once it's in the hepatocyte, it then separates into its parent elements. The ASGPR then goes back to the receptor and the GalNAc gets broken down. And this double-stranded molecule then separates once it's bound to the RISC, RNA-induced silencing complex. Again, natural cell architecture, part of the normal way in which our body degrades and recycles proteins. It separates, the passenger strand goes away, and the guide strand, which is the exact complement, again, A's and T's, G's and C's, to the mRNA encoding the PCSK9 protein. Remembering what PCSK9 is. PCSK9 binds to the LDL receptor and then causes it to degrade, therefore meaning you no longer pull in LDL cholesterol. If you remove PCSK9 from the system, you allow the LDL receptor to continue to recycle, continue to remove LDL cholesterol. Really neat mechanism of action. Same as Repatha, we're achieving it here with inclisiran. What's really neat is that once it's done that, you then remove PCSK9 ability to be able to be produced. And because this sits on the RISC, the RISC, for up to a number of weeks, you then have the ability to dose patients very infrequently. How does it look? This is early dose finding studies from inclisiran. You can see they're varying doses of 200, 300, 500. You see this reduction in LDL cholesterol at around about 30 days from a first injection, and persistence of up to 50% lowering out to almost 6 months. A really neat mechanism allows us to dose this very infrequently. When they study this in a variety of clinical trials, it's always been this same sort of mantra. You get a baseline dose, you get a booster at 3 months, and then once you're at 3 months, you're then on maintenance 6 monthly injections. And what's neat about that is you get this very smooth area under the curve reduction of around about 50% lowering of LDL cholesterol from baseline. Safety profile, so important for a first-in-class agent for LDL cholesterol lowering. Nothing really to see here. We've got about 7,000 patient years of safety experience. We've got about 13,000 patient years of efficacy experience, and we'll have a whole lot more in the next couple of years. But you can see here treatment emergent adverse effects, very similar in both groups. We absolutely see more injection site reactions as we do with Repatha, as we do with a lot of other injections, but they seem to settle over time and don't cause discontinuation. But you say to me, well, yeah, show me the outcomes, Adam. Show me that you've got clinical events, and there aren't any yet for inclisiran. This is pooled data with follow-up that's available in the extension studies of the Orion program, and you can see here that it stands to reason that around about 12 months we see separation in curves of patients treated with inclisiran compared to placebo. But in the next 3 to 4 years, we'll see almost 30,000 participants enrolled in Orion 4 and Victorian to prevent to understand whether or not the hypothesis feels, as we expect it does, that if we can lower LDL cholesterol around about 50% from baseline, we should see a reduction in CV events. So what about beyond PCSK9 and LDL cholesterol? As I said, this is an entire symposium by itself, but this is just a cook's tour. Some new names to get your head around. A bit like ARBs, we've got sartan, and our ACE inhibitors have got prils. Our new suffixes here are ursins, which are reverse sense and oligonucleotides, and cyrans, or small interfering RNAs. These are anagrams. And what you can see here is a variety of new agents coming down the pike. Lp(a) is like LDL cholesterol's evil cousin. Very similar size, appears to be as atherogenic as LDL cholesterol. And we'll have the first outcome trials reporting next year of pelacarsen, Novartis' compound, and olpasiran, which is Amgen's compound. And we'll see whether or not that we can reduce Lp(a) cholesterol. We can see that from the phase 2 data, but whether it then improves clinical events. And then coming very quickly behind that is zerlasiran, lepodisiran, which is Lilly's compound. We're just starting a CVOT with them shortly. And so we're really going to get a sense of whether Lp(a) remains just a marker or is truly something important for risk. Patients have got elevated triglycerides, have been a really difficult group of patients to treat historically despite lifestyle interventions. And there are a variety of different genetic susceptibilities that put patients at risk of pancreatitis. Olezarsen has just been listed in the FDA as an IND agent for patients with hypertriglyceridemia with pancreatitis, can lower triglycerides by about 80%. So ApoC3 is here as well, as is ANGPTL3. ANGPTL3 and ApoC3 both regulate lipoprotein lipases. And so we'll see whether or not reducing triglycerides does impact CV events with some of these agents, which are able to profoundly lower these levels. You say, well, that's great, Adam, so you can get their lipids down with an injection once every 6 months, but they're still on Coveram and indapamide, and they're still on their half a note in the morning. Well, this may not get us all the way here, but zilebesiran is an exciting siRNA drug as well, which hits the angiotensinogen pathway, which is all of the upstream determinants of the receptors we use to treat with quinapril and perindopril and irbesartan. Here, a once every 6 month injection can reduce systolic blood pressures between 10 to 15 millimeters of mercury. So perhaps you're going to be able to get a shot for your cholesterol, a shot for your blood pressure, get a flu vax, maybe an RSV vaccine as well. So I mean, this is not about whether you're going to get an injection, it's which ones you're getting and how many. Allows us to think about models of care. You know, tablets are always going to be there. I've got a bunch of needle phobic patients in my clinic. Tablets are going to be there always, but there's a lot of tablets to have for our patients. Potentially monoclonal antibodies will continue to have a role. Repatha still remains one of the most commonly prescribed drugs in my clinic. siRNAs in a 6 monthly form. And I haven't even touched today on gene editing or epigenomic editing, where you potentially could do once and done interactions where you change the base pairs for these patients. So I want to finish with my last couple of slides on overcoming inertia. I know I'm between us and a panel and lunch, so I'm very aware of staying as best I can to time. We need to try and reframe this. When someone walks into your clinic with a blood pressure of 170 systolic, you don't put them on 2.5 of amlodipine and think you're going to get there. In the same way, when someone walks in your clinic with an LDL of 3.5, 50% lowering with a high-intensity statin is not going to get you to 1.4 millimoles per litre. So we need to start the messaging to our patients that you're going to need to be on 1 or 2 drugs at least for your cholesterol. And the problem is that patients come back to my clinic and say, I'm going to try my diet, I'm going to try my exercise, I'm going to try my statin, whatever else, and they come back and they feel like they've failed, where we know that 80% of levels of LDL cholesterol is genetically determined. And I don't mean by FH, I mean the way in which we all handle our cholesterol is determined by our genes. So if we have this real concern for our patients that they come back and feel like they've failed, in the same way we talk about with A1C, another drug you failed, another drug. We can't let our patients fall into that trap here. We need to start the messaging early, and patients should be discharged from hospital with an ACS on combination therapy. And this is what some of the new guidelines are saying. Patients at very high risk should be started on statin and ezetimibe up front. That's a problem in our PBS. We need to be on 3 months of statin before you get ezetimibe. But I will say to you that off-label prescribing of atorvastatin and ezetimibe generic is $12 a month compared to $8 a month, whatever else. So I don't think it's a big deal for most patients, but it's real. And for patients who clearly have got very high risk, potentially a PCSK9 upfront strategy. Again, not in our reimbursement environment, but the data tells us that if we leave this for other people to do, it doesn't get done. That's all of us included. Eligibility, I won't bore you with some of this to say that it's exactly the same, whether you're inclisiran or evolocumab. Patients need to have symptomatic disease. They need to have an LDL threshold of 1.8 millimoles per litre. Historically, we had a real challenge where patients would have an LDL that was between 2.6 and 1.8, and now the guidelines have changed to allow us to prescribe these agents much more liberally. And this is in the hands of our GPs. I know there are a number of GPs in the audience today, so we now know that the use of PCSK9 inhibitors must be used in GP land because you are looking after the vast majority of our patients' cholesterol. And so this is a fantastic initiative in my mind. The key language here is must be treated by a physician who has consulted a specialist physician. GPs who call me realise that I'm pretty comfortable. It's a broad church. That's a phone call. That's an asynchronous clinic letter. An email, I'm very comfortable. If you're excited about LDL cholesterol, then so am I. Get on board. So absolutely, I think this is so important for GPs to take the bull by the horns. So I'm just on time. LDL cholesterol, causal and cumulative, but in the same way we talk about smoking, is very much modifiable. And I think we need to change the goalposts with which we have our conversations with our patients. There are a variety of unmet clinical needs. Despite statins being incredibly effective, safe, and cheap, we struggle with adherence, and we're leaving our patients behind with their goals. We know there's a need for newer therapies that are less frequently administered, that can optimise adherence, and that there's a very exciting opportunity for us to have a variety of new drug targets, which will mean ultimately we'll have so many different therapies. We need to work out which is the right therapy for which patient at the right time, and how our government can pay for that. We need to reframe this LDL cholesterol as being a multi-drug disease. And there's a simple arithmetic that if you are not going to get 50% lowering to your target, you're going to need to use more than a statin. Inclisiran is now approved. It's an easy drug to use. It's effective and safe. Outcomes data is pending. And I'm really excited that as an interventionalist, that perhaps I'll be a little less in my job treating coronary disease focally, but in a very systemic way. So I'm excited to stop there and take your questions in the panel. Thanks for your attention today.
Thank you so much, Dr. Nelson, for providing us with your very valuable insights. We now welcome everyone to participate in our next Q&A segment. There's a couple microphones that are roaming around.
Dr. Nelson, thank you so much for your presentation. Just would like to ask a very quick question about checking the lipoprotein A, lipoprotein B, and C when it comes to the assessment of the LDL. Do you do that usually? Do you encourage the GP to do that as well?
It's a great question. I gave very little airtime to Lp(a). Lp(a) is still an expense to patients. It can be $30 to $50. Some private labs even $100. It costs about $9 to perform. So there's a huge markup on this. MSAC are reviewing it currently to see how we can get this for our patients more. The European guidelines suggest that all people should have their Lp(a) checked at least once in their life. And the nice thing about Lp(a), it doesn't move much. It's very ancestrally driven, and what you have when you're 30 is the same as when you're 60. So if you know your Lp(a) early in life, then you know you're not going to have Lp(a) mediated risk. So to answer your question directly, do I measure Lp(a) on every person? No, I don't. I measure it when I've got patients who have got disproportionate ASCVD that I can't explain for other reasons. And that's important because if patients come in to me with an LDL of 5, cigarette smoking, diabetes, I think, okay, I can understand the proportionate burden of your ASCVD. If someone comes to me with an LDL of 2.2, for example, is lean, has got no other real traditional risk factors, that's my Lp(a) candidate. And in general, it's patients under 50 that I think about as well. Well, I'm worried about it familially because it's ancestrally driven, and so often there's really a nice opportunity for cascade screening. So patients who come back with an Lp(a) of 300, for example, remember that a normal level 50 to 75, depending on nanomolar versus milligram per deciliter. So I would do it in younger patients because then there's an opportunity to be able to cascade screen individuals. At the moment, we don't have therapies that can move the needle on Lp(a). So what's the information useful for? Well, I then intensify risk where there are other risk factors. So it's a bit like, I will therefore shift my goalposts about their A1C perhaps. So I'll talk more about weight, other modifiable features, until we have agents that clearly show that lowering Lp(a) results in benefits.
I would like to add a little bit on Lp(a). Sorry. It's actually quite nice that we are checking it more often now in these sort of circumstances. I would give you an example. I have a patient who is basically very well controlled LDL 1.6, total cholesterol 3.4. She had acute coronary syndrome, PCI to circumflex, and then come back with another unstable angina. I did the LAD stenting. Then keeps on coming back with chest pains. I initially thought that she might have some spastic component, but then she comes with small troponin rise as well, and I thought, let's take her to cath lab again. Within less than 12 months, she had quite significant neoatherosclerosis in LAD stent. So she's not obese, she's not, her dietary habits are quite good. I said, look, let's check for other causes. And her LP little a was 0.9. So it was quite high. So 1 and above is quite significantly high. She was not far from there. So yes, we don't have a treatment yet, but we are obviously, we should think about it, and especially in recurrent presentations with good risk management. Hopefully we'll be getting treatment soon. We have lots of medications on, which are on trial right now.
Assalamu alaikum and good afternoon, everyone. My question is to Dr. Zafar Usmani. I'm working as a GP, so just considering a scenario, a truck driver patient who has already established obstructive sleep apnea and on CPAP machine comes for a repeat script and let me know that just a couple of months back he had a bariatric surgery and Dr. Shalub has probably bring him down 15 kilo less, and now he stopped using the CPAP machine and feeling better. What should we do? Should we do a repeat sleep test or should we send for a specialist review?
Yeah, so very good question. So basically in that context really depends that 15 kilograms of weight loss is how much is that from baseline. So generally you would take that in terms of percentage. So that weight loss, how much, what sort of BMI has gone down. And if it's at least more than 10% or 15% of their baseline weight loss, then once they reach their target weight loss, then you should ideally do a sleep study to basically prove for various reasons. For obviously we've seen cardiovascular and road traffic accidents that just that they don't have any sleep apnea. Now again, this would vary patient by patient. If the patient has quite severe sleep apnea, like the AHI was 120 and they come down from 150 to 135, there's a fair chance they might start feel better, but they might still have sleep apnea. So again, it's a combination of clinical symptoms, but also risk factor profile. If they're high risk, then I would suggest to them that, look, don't stop the CPAP machine, but let's do another sleep study and then we'll make a decision. Sometimes they find they've lost weight and CPAP is very hard for tolerate because they need less pressure. So you can always do pressure adjustment, reduce the pressure, get a download. So stopping a CPAP is not just something I would generally basically leave in patients' hands that say, look, you've lost 15 kilograms of weight, stop the machine. Generally speaking, we should do a repeat sleep study once they reach their target weight loss. But in the interim, if they're feeling it's uncomfortable, you can always do another sleep study or just reduce the pressures first and then take it gradually. But again, it has to take case by case basis. If it's a truck driver, obviously you would take it very, very cautiously that no, I would not suggest you stop sleep until we do a sleep study and prove that you don't have sleep apnea anymore.
Over here. Me again.
Can't see you, sorry.
Do you want me to stand up?
Oh, just I'm a bit hypo.
Bit hypo, exactly, I think people would be cursing me after asking me this question. Anyway, my question is for you as well. Just going back into this scary video that you showed to us when the two truck drivers just sleeping together. So the question came to my mind. So my question is basically twofold. The first one is, in general practice, we do see patients when they cannot tolerate the CPAP treatment because of whatever reasons. So they ask for the alternatives, and one of the alternatives you have mentioned before, which is MAS, so mandibular advancement splint. So nowadays, these splints are easily available over Amazon or from the pharmacy. So is it recommended for these patients to buy those from over-the-counter or from online websites? Or do they need to see the ENT surgeon? So this is the part A. So the part B is if they do go that part when they use the MAS, how do you know the compliance? Because you don't get the chance to see the download, especially when they come for the driver's medicals, light vehicle even, because they don't need to go and see the specialist. So how do you know the compliance and what do you recommend for the MAS?
Thank you. So yes, look, obviously, if someone has sleep apnea, you offer them CPAP, they're not compliant. MES is an option, mandibular advancement splint. The online ones, they're not recommended because you don't know what they're going, what they're buying. It's about how it works is bring your jaw forward and there's readjustment. So if they only have very mild sleep apnea, they've gone and buy online, they might be lucky it's working for them, but from pure treatment perspective, they should see a dentist or a mass specialist, and I think I'm pretty sure Sarah would talk about that, and get a proper assessment. So not an ENT surgeon, but a dentist, and there are lots of dentists who do the mass, so they should get a proper splint, and there are ways to see their response. I'm pretty sure there's some download things coming up, which we'll probably hear about that as well. But generally speaking, yes, online devices are not recommended. You can't say that, look, it's treated. If they have gone and they really try to convince you that I have an online device and I feel well, do a sleep study on MES. Do a home-based sleep study with MES, just to prove objectively it's working for you. But generally speaking, they should see a proper dentist, get it done properly, because then they can readjust depending on their review and everything else. The second question, the second part, was how...
How do you know that with the MES, the sleep apnea is getting...
So again, it's a subjective thing. So obviously, you probably have to trust them from the history-wise. Do the ESS. I'm not sure. I did hear there's some tips might be coming in as per the compliance, and I'm not sure with some apps and everything else. I'm not sure how far we are with MES, but that might be in the scenario coming in a few years' time. But if you're really concerned, for example, it's like a truck driver who's got a MES in, and you're saying, look, you got a mandibular advancement splint, and he's saying it's fine, but you have some suspicion there might be something gray going on, because ESS, they go on Google, they know they have to put 000. You should do a maintenance of wakefulness test. So then you say, okay, that's fine. You go ahead and do a maintenance of wakefulness test, which is objective assessment to see if they're falling asleep or not. So in those extreme scenarios, you should see the objective measures. But generally speaking, obviously, you just document everything the patient is saying, is feeling better and everything else. But yet, there is nothing like that as with CPAP just yet. Sorry?
He's saying, is it easy to just refer to you?
Yeah, I will take the burden for you. Thank you.
I have a comment for Dr. Lee and question as well. What's this special on this M sign on the roads?
Sorry, the question again?
So there's a guess here. So what's the special about this M sign on the roads everywhere?
M sign.
Salim.
Oh, I see. The double arch. Okay. Yes, what's your question about them?
What do you think? So is it like affecting our brains to go there, our children to go there and eat McDonald's? Or,
actually...
because they have some sort of charisma that which children actually always attract to.
Well, I actually think that it is not a specific single thing that we can put our hands on. Unfortunately, there was a movie sometime back, Super Size Me. I think some of you might know that. But that was actually very fake, isn't it? It's an N of 1 and the person purposely chose all the most unhealthy stuff from McDonald's. On the other hand, we have the Guinness Book of Record. You know, the man who ate the most Big Macs? There's a Guinness Book of Record for that. I think he's eaten about 34,000 plus Big Macs by now.
Is he still alive?
He's still alive. He's seen by a cardiologist every week or every 2 weeks. And the cardiologist has given him a all clear, and also sees a GP. He's from America, and he's still ongoing, taking 2 Big Macs every single day. So, and he's actually not that big or obese by our measure. His BMI, I think, is probably under 30, but not sure if he's slightly overweight. So look, it's not a single thing. You have to look at it as a whole system thing, right? Certainly, I don't normally recommend it. The carb there is probably a bit higher, but frankly speaking, turns out that my maintenance requirement for my patients tends to be about 100 grams of carb, which is low carb. And guess what? 2 Big Macs is about 105 grams of carb. So there you go. So maybe he's making it still low carb.
Can I ask a question from Tien?
I don't recommend Big Macs, okay? Please. Don't get me wrong.
Great talk, by the way. So you talked about visceral fat. Is there any simple, practical measure which we can perform in a GP setting to look at the visceral fat?
So waist circumference, I mentioned early this morning, is probably the best surrogate marker according to the studies. It was actually superior to waist-hip ratio, which is the WHO definition for metabolic syndrome. It's changed since the European time, and till now we still use waist circumference. But so waist circumference, the only problem is the variability. You need to make sure that you measure it correctly. And the other thing about it is if anyone is going for a bone density scan, they generally don't charge extra if you just add on a body composition scan. The problem is some of them, they come out with just raw numbers and you don't actually know how to interpret them. Okay, but generally you need to know that visceral fat is not that much. If you have 1 kilogram, it's probably on the high side. Yeah, it's not a lot. So I would recommend doing a bone density for the elderly because again, metabolic syndrome tends to be more in the elderly. The older you get, the greater you have all this. Yeah. So just remember that if they are going for bone density anyway, get it done, free.
One last question by Dr. Salim Chaloob.
Yeah, thanks. It's Salim Chaloob, I'm a bariatric surgeon. Thank you so much. You guys addressed really a hot topic with this session. Just adding to the sleep apnea for Zafar, and when we check it, normally patients who has had a bariatric surgery, the aim for it is to lose excess weight over 60 to 70%, ranging between 12 to 18 months. The sleep apnea is a condition diagnosed earlier on those patients who's got obesity and then appointed on their medical record been suffering from a sleep apnea, and the health link now, it's quite obvious that they have got sleep apnea for life unless you remove it. In those obese patient who's got a sleep apnea related, what we normally do after 6 months, and if we notice that there's 30 to 60% excess weight loss, we recommend them to repeat the sleep study, particularly if the pressure reduced over that time. The idea of that is to making sure is not just the obesity causing that sleep apnea. It could be anatomical variation or problems related to ENT, which need to be looked after or looked at to make sure that this patient is not going to be labeled for life, sleep apnea related to obesity. So we do recommend that to monitor the weight loss over the first 6 months, and then 12 months and then 18 months with the result of either completely removed after excess weight over 70% gone, or to have another subspecialties to look at the reason of the sleep apnea, which by the end of it, that meaning we re-refer the patient to you. Thank you.
Exactly what we discussed, that you have to do a sleep study before you declare them they don't have sleep apnea. Yep. Thank you.